Evaluating extrapulmonary tuberculosis. The two types of clinical manifestation of tuberculosis are pulmonary tuberculosis and extrapulmonary tuberculosis. The former is most common. Extrapulmonary tuberculosis refers to tuberculosis involving organs other than the lungs, such as pleura, lymph nodes, abdomen, genitourinary tract, skin, joints, and bones, or meninges. History. A detailed history is vital to assess risk factors, for example, exposure during work or home environment, prior treatment, intake of immunosuppressant drugs, any chronic illness, hormonal treatment for infertility, and surgical manipulation. The patient may complain of general symptoms, such as low-grade fever, night sweats, and weight loss. Specific symptoms depend on the organ involved. Miliary tuberculosis, also known as generalized hematogenous tuberculosis, miliary tuberculosis, occurs when a tuberculous lesion erodes into a blood vessel, disseminating millions of tubercle bacilli into the bloodstream and throughout the body. The lungs and bone marrow are most often affected, but any site may be involved. It is most common among children less than 4 years of age, immunocompromised people, and the elderly. Look for the following symptoms in such patients: fever, chills, weakness, malaise, and often progressive dyspnea. Intermittent dissemination of tubercle bacilli may lead to a prolonged fever of unknown origin. Bone marrow involvement may cause anemia, thrombocytopenia, or a leukemoid reaction. Genitourinary tuberculosis. When the kidneys are infected, manifestations of pyelonephritis, such as fever, back pain, pyuria, may be noted. Infection commonly spreads to the bladder and in men to the prostate, seminal vesicles, or epididymis, causing an enlarging scrotal mass. Tuberculous meningitis. In areas where tuberculosis is common, among children, TB meningitis usually occurs between birth and 5 years. At any age, meningitis is the most serious form and has high morbidity and mortality. When tuberculous meningitis is suspected, look for the following symptoms: low-grade fever, unremitting headache, nausea, and drowsiness, which may progress to stupor and coma. Kernig and Brudzinski signs may be positive. Tuberculous peritonitis. Peritoneal infection represents seeding from abdominal lymph nodes. It is common among alcoholics with cirrhosis. Symptoms may be mild, with fatigue, abdominal pain, and tenderness, or severe enough to mimic acute abdomen. Tuberculous pericarditis. Pericardial infection may develop from foci in mediastinal lymph nodes or from pleural tuberculosis. Patients may have a pericardial friction rub, pleuritic and positional chest pain or fever. Pericardial tamponade may occur, causing dyspnea, neck vein distension, paradoxical pulse, muffled heart sounds, and possibly hypotension. Tuberculous lymphadenitis. It involves the lymph nodes in the posterior cervical and supraclavicular chains. Patients affected with cervical tuberculous lymphadenitis show progressive swelling of the affected nodes. In advanced cases, nodes may become inflamed and tender. The overlying skin may break down, resulting in a draining fistula. Cutaneous tuberculosis. Cutaneous tuberculosis results from direct extension of an underlying tuberculous focus to the overlying skin, forming ulcers and sinus tracts. Investigations. Most patients have a positive tuberculin skin test result and a normal result on chest radiography. Excisional biopsy of the lymph nodes with histology, AFB stain, and mycobacterial culture is the diagnostic procedure of choice. Fine needle aspiration is more reliable in patients with HIV infection because of the higher mycobacterial burden, and in these patients should be the initial diagnostic procedure. Polymerase chain reaction for Mycobacterium tuberculosis on the fine needle aspiration specimen Enhances test sensitivity. To get more such high-yield medical content, don't forget to subscribe. BasidiaMED. The easiest and fastest way to take advanced clinical history.